Hello, my name is Arshad Kudrolli. I'm going to tell you about experiments and work that we have done with Dr. McGee's group. Dr. McGee is a critical care physician, and his group of respiratory therapists had a question. The question was that while treating patients with respiratory disease, one normally treats them with primary oxygen therapy devices. So these are devices such as the nasal cannula and the simple O2 mask, which are shown in these two examples, which you see the photographs, while the patient may be at home or being transported to a healthcare facility or in the healthcare facility itself. In this case here, you have healthcare workers who are closely interacting with the patient who is suffering from shortness of breath. Here, one treats them with supplementary oxygen. And here the question is, what is the role of the supplementary oxygen in dispersing the exhalations coming out of the patient here who's suffering from COVID-19 or some other respiratory disease, and therefore the exhalations might contain some virus particles as well. So here, our goal is to understand the primary oxygenation devices, which is nasal cannula or simple O2 mask. They are typically used when the patient first arrives or seen to give them oxygen, which makes them easier to breathe. And the question is that by using imaging techniques, can we visualize the flow and the direction of the oxygen and the exhalation, which directions they go, which places to avoid if you're the healthcare worker, if the patient is not wearing a mask, or if they are wearing a mask to help mitigate the spread of the exhalation. So the system we are using to investigate is a mechanical lung simulator system. So we can, in fact, do repeated experiments in the same conditions. We can vary the breath cycle, the frequency, and how much volume is expended for a younger person versus an older person. And we can also tag the particles with higher concentrations of aerosols that we can then see in more greater detail as to where they spread and what direction they spread. So those aerosols are a few microns in size, and they are composed of water, glycerol. There are no virus particles in the study that we did, so we could do them safely and repeatedly with the help of our students. So here is an example of what we observe. So here is a mannequin which simulates the human head. And here we have a nasal cannula which is being fitted on him, on this mannequin, and the mouth has been taped shut. So we're just looking at exhalations which are coming out from the nose while supplementary oxygen is being fed here at about 4 liters per minute. All right, and you can see that most of the exhalation is coming straight forward. The fact that there is a nasal cannula there does not obstruct the exhalation plume coming out. It still is very strong as it goes forward. And so when you average, it's going straight forward above the nose. And if the head is tilted down, it's still going in the sort of in the same direction relative to the plane of the nose and the face. If the patient is breathing out through the mouth, as is typically the case when one is having difficulty breathing, then here the plume goes out a little bit higher compared to when it's coming out from the nose, right? And the Reynolds number here is about 2000, so we are reaching the turbulent limit of the plumes coming out. So one can ask, well, how much of the aerosols are concentrated in this cone, which you can sort of summarize here, indicated by those 2 lines. And we find that that angle is about 25 to 30 degrees. It is not typically disturbed, if you like, by the flow rate coming out of the nasal cannula or the simple O2 mask. So the treatment rate doesn't seem to change that cone angle. It comes out still as strong. In both cases, there's a difference in the sense that the nasal cannula, the plumes come straight forward, whereas in the simple O2 mask, the mask redirects the exhalations and they come off to the side. So there are different areas which have greater concentration here of the aerosols. So for example, in the case of the nasal cannula, the concentration is about 40 times higher than if the exhalation was spreading uniformly around the face of the mannequin in this case, or it would be about 15 times higher in the simple O2 mask, but in two directions. So 15 times higher concentrated in this direction, 15 directions to the side in the case of the simple O2 mask. So clearly this is a risk if you're standing in front while giving care to the patient. So how can we mitigate this? And one strategy is to use a lightly fitted, simple surgical mask, the kind that we've been using, and just put it over the nasal cannula or the oxygenation device here. So one on the right there shows that situation. You can see that the exhalations which are coming straight forward up through the nose and mouth in the left case is now to large case mitigated and redirected because these exhalations are now being sent back away from the faces of the caregivers who are hovering or working about them. Similar mitigation is also reached with using the simple O2 mask. So here, remember, this is looking at it from the head down. And so you have two plumes coming out from the side, side to side. And so the movie on the right shows the example when you have, or when we have a surgical mask, again, fitted loosely so that, the patient still doesn't have an issue exhaling. Here you can see again that the strong plumes upward directions have been suppressed and the plumes are now going off to the side towards the shoulder of the patient. So anyone working over them does not have the plumes coming directly at them. So one can quantify this now by mapping the light intensity to the aerosol density at that location. And so here, as a function of angle above the head, you can see that there's a directed concentration right in front and above the head of the patient while wearing a nasal cannula. That density decreases as you go away from the patient. But as soon as you wear a mask, the whole aerosol is redirected, and as a consequence, there's a huge suppression of the aerosols which are directly dispersed in the front. So the mask is, as you see, help mitigating the exhalation risk posed by an infected patient. Similar situation with the simple O2 mask. Here you have two plumes, so therefore two angles at which it's coming out. There are two peaks. Again, by wearing a mask, you can bring down the intensity of the exhalation in those two directions considerably. So how much? It's compared to 90%, which is typically exhaled in the forward direction while not wearing a mask. As soon as you wear the mask or the patient wear the mask, you can redirect the exhalations downwards and therefore above the patient, you get as little as 10% now coming up. So from 90%, we're bring it down to about 10% in both cases. So with that, let me quickly summarize the main results. So here, what we've seen is that while wearing a simple O2 mask, even though there is a word mask in there, it actually just simply redirects the exhalation of the patient. So there are exhalation jets or exhalation plumes present in the simple O2 mask, as well as the nasal cannula. The direction in which this exhalation exists is different, straight up and forward in the case of the nasal cannula, towards the side in the case of the simple O2 mask. Then we have shown that if you cover the device with a simple surgical mask, and that too lightly, it will redirect this exhalation. And so the exhalations will not reach people working around the patient directly, and therefore reducing their risk. So with that main points, I would bring to your attention a couple of publications we have where we discuss this technique and the results in more detail. And again, I will be happy to take questions via email if I can't make it there in person. Thank you for your attention.